I mean, I know it would be for me. I mean, but there's doctors that practice in all kinds of settings. If you're talking about somebody that's practicing in a Medicaid clinic setting at a hospital where they're seeing predominantly, patients that are at a low socioeconomic status, where you're lucky enough if they drink their bowel prep to begin with and show up to the procedure because, they have challenges just doing the standard colonoscopy, then this is not something that they're going to be jumping for right now. So
Okay.
I think it depends a little bit on the doctor, and the setting. And there's a very diverse range of healthcare settings in this country, more so than in other parts of the world, in my opinion. So nothing's going to be. You're not going to find a 100% uptake on anything. I mean, there's only 40% uptake on colonoscopy to begin with. But presumably for this product to be successful, it's not something that every GI is going to use.
Yeah. So do you use the product Eleview? The other product that they have?
No, but I am familiar with it. That I think is a different. That's kind of a harder sell for me. I mean, it's not a clinical situation that we're in that often with screening colonoscopy that we have to use to raise the polyp up. This is basically a polyp this is basically a market for probably mostly for advanced endoscopists that do a lot of complex polypectomy, so I think you're talking. I mean, I haven't used this. I know it's available, and about it. Bottom line.
So it's not a typical.
Not at all.
Product.
I mean, for me, we're talking about less than probably 5% of all colonoscopies I do would even have a need for an agent to lift a polyp up, and frankly, this is not. This is something where I don't think there's a huge unmet need. I seem to do fine with the regular saline injection. And now there are some docs who just do complex colonoscopy all day long, and for them this may be a huge boon, to have this agent that stays in the submucosa for longer and has dye in it and all that. But for me, it's kind of like, it sort of seems sort of cool. If I had it, I would use it, but I'm not dying for my center to get this, and I certainly don't want my endoscopy center to have to incur additional cost when we're already working on a relatively narrow margin here for this.
Okay. That makes sense. Yeah, because that's not been. They've had kind of slow uptake of that product, and
not surprising.
But the kind of the rationale for that to then say that the methylene blue MMX products would be slow is they're completely different markets, right? There's no reason to suggest one is a good proxy for the other.
Completely different. I mean, on many levels. One is just financially, this is something that we'd have to buy as an endoscopy center, and the patient's not buying it. And number two, the market. I mean, it's an astronomically higher market, but by numbers of patients for the blue or methylene MMX, whatever you call it, than this. This is a really kind of special situation that we encounter from time to time. We only find polyps to begin with about 25% of the time, and the majority of those, overall, the majority of polyps do not require lifting. So this is a really small market compared to the.
Okay, that's clear. And then the other product they're working on, I think they in-licensed it just to fit with their other products, is a fast-acting sedation, which is supposed to remove the need for an anesthesiologist in a colonoscopy. Would that be something that you could envisage having good uptake because of the cost savings?
That's a complicated question. So, I mean, the bottom line on that one, from my perspective in my practice setting, is actually we don't want to remove the anesthesiologist. Multiple reasons. One, I don't want to have to give sedation myself. That's how we used to do it. But that just more